So we'll be talking about chest tube today. So we'll be talking about the indications, contraindications, of the procedure. So the indications of a chest tube insertion is basically in emergency you put it in patients with pneumothorax and hemothorax. Contraindications, you don't want to do it in patients with with a deranged coagulation profile. And you avoid it in local site infections. Then we'll also talk about the complications of the procedure. So this can be a pneumothorax in itself, hemothorax, lung contusions, primarily. Okay, so when you talk about the procedure, I have divided it into steps and there is a mnemonic for it. So pick them. So P starts for prepare and position. I stands for inform. C stands for clean hands, consent. D stands for drugs. E stands for equipments. And M stands for monitoring. So when we are talking about the chest tube, we prepare an appropriate size chest tube. For example, for hemothorax, we do a 32 French chest tube, and for pneumothorax, we do 24 to 26 French chest tube. And we prepare the chest tube insertion tray. Position, we need to know where exactly we put in the chest tube. So we put it in the triangle of safety, which is bordered by anteriorly by the pectoralis major, posteriorly by the latissimus dorsi, and inferiorly by a line drawn through the nipple. The appropriate place to put a chest tube is in the 4th or 5th intercostal space in anterior part of mid-axillary line. In the triangle of safety. Then we inform the patient about the procedure, we clean our hands, we gain appropriate consent, and then for drugs we usually talk about the lignocaine. So we use 1% lignocaine. With a maximum dose of 3 mg per kg. Equipments, we need to know that we need a chest tube, we need appropriate chest tube insertion tray in which we have an artery forceps, we have a chest tube with trocar, and we have a suture to secure the chest tube. We also have drapes to draping that area. Any procedure or chest tube insertion especially is done with monitoring. So we need chest leads on, we need a blood pressure, pulse, saturation, respiratory rate, and a rhythm on the monitor while doing the procedure. Another important point to remember while chest tube insertions is an underwater sea. This consists of a bottle with water in it and the chest tube connection entering and lying below the water, so that every time the patient respires, we see bubbles in this water bag, which confirms the position of the chest tube. So when we do the procedure, our first step is to clean the area, as we talked about it already. So we clean it with antiseptic and betadine. This is the triangle of safety that we go into. Then we recognize the fourth and fifth intercostal space, and we go in the upper border of the lower rib, because we are trying to avoid the neurovascular structure. The neurovascular structure in the intercostal space lies usually in the upper rib, in the fashion of vein. So we have the intercostal vein, the artery and the nerve in the upper border, in the lower border of the upper rib. So we have to go in the upper border of the lower rib to avoid the neurovascular structures. So we begin by using 3 mg per kg as a maximum dose of lignocaine, and with a 25 gauge and a 21 gauge needle, we anesthetize the skin and the subcutaneous tissue, followed by the pleural space in the upper border of the lower rib. Then we take a blade and make an incision in the upper border of the lower rib. An incision big enough to be extended by artery forceps. Then we use these artery forceps to widen this incision. This is usually a blunt artery forceps to avoid damage to structures around. When this blunt artery forceps enters into the pleural space, we get a feeling of give. Which confirms that we are into the pleural space. Then with the help of our finger, we recognize the pleural space, and then we take a chest tube. Depending on whether we are trying to drain a pneumothorax or hemothorax, we choose a 24 French for a pneumothorax and a 32 to 36 French for a hemothorax. We clamp the chest tube anteriorly and posteriorly, and then advance this chest tube into the pleural space. We can advance up to the mark of 10 to 15 on the chest tube. Once in the pleural space, we open this clamp, the anterior clamp, and then we connect the other end of this chest tube with the underwater seal. Finally, we open this clamp and we will see an air column moving in the underwater seal, which confirms that we are into the pleural space. This is followed by securing the chest tube. So we secure the chest tube on the chest wall by suturing first to the skin and then to the chest tube. In a figure of 8 fashion. This is then secured to the chest wall anteriorly with the help of a tape, and then we basically dispose all our shafts and end our procedure.